Hi, and welcome to Sientra's Tech News. I'm very pleased today to be able to talk with an expert panel of surgeons on the topic of mastopexy augmentation, probably the most difficult surgery in all of cosmetic breast surgery. This will not be done in a single episode, so we'll do a series and we'll dig in a little deeper. Without further ado, I'd love to introduce our expert panel. First, out of Louisville, Kentucky, Brad Calobrace, who's written on the topic several times and has several published chapters and more to come. Thanks, Brad, for being on.
And thank you. Thanks, Blaine. I'm glad to be here.
Great. And next, out of Nashville, Tennessee, is the Mindy Haws. Thanks for being on, Mindy.
My pleasure. Great.
And next, out of Miami, Florida, is Dr. Jason Altman. Thank you, Dr. Altman, for being on with us today and for the discussion.
Happy to be here.
Great. And last but certainly not least is Dr. Rob Cohen with practices in Beverly Hills, California, as well as Scottsdale, Arizona, who's written, again, several chapters and papers on the topic and several more to publish this year. Thank you so much for being on with us today, Dr. Cohen.
So much for having me. I appreciate it.
With that, let's get to the panel and get everyone's opinions here. Top line, first off, how about start with you, Dr. Calabrace? What are your top considerations for performing a successful mastopexy augmentation concurrently while minimizing complications?
Yeah, I think with an augmentation mastopexy, it's always the balance between efficacy and safety in the procedure. And can you achieve the results? Can you achieve them in a safe manner that has a low complication rate? And can the results with that combined procedure be the same as it would be if you did them separately as a staged procedure? And that's what you're always trying to balance and sort of figure out. So when I look at patients, I see the patients that would require an augmentation mastopexy are either patients who come in for an augmentation, and that's basically what they need, but a small mastopexy is going to improve the overall results by maybe positioning the nipple areolar complex in the right location or just dealing with some additional tightening of the skin envelope. Then you have a whole nother set of patients who actually need a breast lift. They have ptotic breasts, maybe larger breasts. There's a lot of ptosis presence, but that adding an implant will actually achieve a better aesthetic result, especially as it relates to the upper pole, giving them volume. So they really need a breast lift, and I'm using an implant as a way of enhancing the shape of that breast more than I'm doing an overall augmentation of the breast. So if I start there, I have a better sense of these two major categories of patients that I'm looking at, and I'm figuring out, is this an augmentation with a mastopexy, or is this a mastopexy that gets a little bit of augmentation? If I start there, it helps me to sort of guide my planning.
Great. That's a great point, and we'll definitely dig in that a little bit deeper in this discussion. Let's go to you, Dr. Haws. What are your critical points for managing these patients' expectations and the plan?
I think patient expectations is the biggest thing. And so much of is getting an idea what the patient thinks they need versus what they really need to achieve their desired results. And are their desired results even possible? And I think using your before and afters are really critical. Talking about what Brad talked about, implants have changed so much now that we can use them not just to fill the breast up, but to shape the breast. So talking with the patient, seeing what they want, and then seeing what is possible, and then using all the tools in my armamentarium to get them as close to their desired result as possible.
Great. Thank you so much, Dr. Haws. And again, we'll definitely get into the technology stuff, Sientra and non-Sientra technologies, how they can help. Let's go to you, Dr. Cohen. Top line things, considerations for making sure this is successful.
So obviously all the points that have been made previously are excellent points. To add to that, I think really in terms of patient evaluation, I think it's really important to get an understanding of the tissues you're working with, because that's going to make a big difference. Skin quality is probably one of the most important things. Density of the breast tissue that you're working with, whether you're going to have to add obviously, if you have to add volume with an implant, or you have to take out some of the natural breast tissue to avoid a waterfall deformity, those things. So I think a really careful examination leading into the surgery is important. And probably a second thing that hasn't been brought up as much so far is flexibility during surgery. So I think with a lot of these surgeries, it's not quite as predictable necessarily as just doing a straight augmentation or something like that, where you may not know until an implant's in place what exact size you might want to use, how is the skin going to look once a patient's in a seated position with with the implant in place, what exact mastopexy pattern might they need. So if you leave yourself some wiggle room to allow for different possibilities, once you see what things are looking like in real time, I think it helps you to get the best possible results for the patient on the table. And obviously that requires extra discussion with the patient to make sure they understand all the possibilities that might happen during surgery and make sure they're all open to you as a surgeon.
Great points again, and it sounds like multivariable calculus in the planning and in the OR, so props to all of you for doing good work. Dr. Altman, from your personal experience, maybe your top ideas of what's going to make the difference between a good and a bad outcome here.
Sure. So I think everyone's touched on the major key points. For me, patient selection, patient education, right? So the first side is making sure that this patient is a safe candidate to use an implant at the time of mastopexy, and I have my criteria for that I can get into in more detail later. The second is making sure the patient understands the role of the implant and the role of the lift in this surgery. I'm from Miami, so there's no such thing as breast surgery without implants. In Miami, I get asked to do breast reductions with implants every day. So the implant is sort of an essential characteristic of that breast surgery, but I make a very big point when I discuss this with my patients that the role of an implant in a mastopexy is very different than the role of an implant in an augmentation. The implant's role is much less about enlarging the breast and much more about shaping and filling the upper pole. I also have a very big discussion with them about the limitations of choice when it comes to size of implants in a mastopexy augmentation. A regular breast augmentation, I give my patients a lot of freedom of choice. In a mastopexy aug, I'm strictly asking them, you want to be a lot bigger or a little bigger? And other than that, there's really very little role because I need the dimensions of my implant to match that space to provide the proper role that I'm looking for the implant to do in that surgery. And then the last thing I'll just touch on is expectations. I make a big point of making sure I explain to patients if they're going to have a mastopexy augmentation, the only pictures they're allowed to show me are of other patients that have had mastopexy augmentations. I will sit with them and delete augmentation pictures from their phone so that they're no longer even considering that as a possible outcome. Because I think you really have to distinguish what's feasible in a patient with excess skin or excess breast tissue versus someone that just has a lack of adequate breast volume.
Great. Excellent points to add there too. So let's get started from the beginning with the end in mind. Dr. Calobrace, you wrote a great paper in 2013. Love to hear if there's updates. But at the time, you were comparing 332 patients with simultaneous breast augmentation with mastopexy versus 90-something with mastopexy alone. And one of the main points that you said is the patient selection. What wasn't seen in the mastopexy aug in that paper were the people that you didn't include, including former smokers or current smokers, obesity, and as well as people who didn't want to sign on to your plan. They needed a lift or more a significant lift, but they didn't want it. So that actually could change your choice a little bit. So let's start with you from the planning perspective. When you're counseling with that patient, who are you deciding, well, we're going to do this in 2 stages based on tissue and their lifestyle?
Yeah. Well, let me say that, the idea of having a patient come in who maybe doesn't want to lift and they've got some level of laxity and skin envelope, and that they really need a breast lift to get the best result, the worst thing you can possibly do is place a large implant into that skin envelope to try to fill it out and somehow make magic happen, because it doesn't make magic happen. It makes long-term bad results. And we all deal with those revisions all the time, the mistakes made over and over. So, and I believe me, when we're at meetings, they go through these they'll show these cases and say, would you do a breast lift or just an augmentation? The number of surgeons who vote for just an augmentation, where every time I'm like, no, I'm going to do a breast lift with an implant in this particular patient. So if you become comfortable with the techniques, you begin to use mastopexy much more often in your patients, So I think feeling comfortable with your techniques that get a great result is extremely important. As it relates to staging, I think there are patients who I do a better job, either because of safety, but more because of the long-term results are going to be better for staging them would be in a patient who's got a lot of obesity, who's very, very large pendulous breasts, where I think it's going to be very hard, especially if they need a significant reduction in volume. I can take out modest amounts of reduction out of the lower pole. Matter of fact, I do it in every augmentation mastopexy I do. I debulk the lower pole and I put an implant to the upper pole. But when they need a large reduction, then I think they're probably better served by doing that reduction in the most significant type of cases you've seen, and come back later and put an implant in if you need to. I also think when you have, somebody that's obese or has large breasts, somebody that has significant ptosis is so great that I think the challenge of putting that nipple-areolar complex up on a medial or superior pedicle is going to be a super challenge to them, and also put in an implant at the same time and keep their nipples alive. So I've always said when I have to raise the nipple-areolar complex more than 5 to 6 centimeters, so if we're in that 8, 9 centimeters from where their nipples lie to where I think their nipples need to be, for me, that's a challenge to do that as a simultaneous procedure and get a really great result. And so I tend to want to stage those patients. Also, patients that are smokers, patients that have unrealistic expectations, because an augmentation mastopexy is more challenging than either procedure in of itself, with a higher complication because the complications are additive or also that. So Bill Adams published a paper where he talked about the idea of vertical excess, saying that if you do patients as a simultaneous procedure who have less vertical excess, and in his paper it was 6 centimeters or less, then he feels those are patients who you can do simultaneously. But when they have vertical excesses greater than 6 centimeters, in my paper I said greater than 8 to 10 centimeters. So when their vertical excesses of 10 and 12, meaning there's a lot of extra vertical skin, that those may be patients that I will just get a better result if I stage them. But I think what you do is you become a more experienced surgeon and more experienced at augmentation mastopexy. You start there, and you become a little bit more cavalier, and you get more comfortable with doing more challenging cases. But it's not where you start. You get comfortable with a starting point, and then you build on that to who you feel you can get a comfortable, good result with that's safe and gives you a great long-term result with that. But those are some of the sort of criteria. It's vertical excess. It's how far I have to lift the nipple-areolar complex, how large and pendulous the breasts are, that maybe would just serve better with the stage procedure.
I think it's also important to talk about the previous augmentation or the previous reduction patient or the previous lift patient. The further along I get in practice and the more breast surgery that we've been doing over the last 25, 30 years, the more of those patients that are out there. So I think those are patients too that you may want to take out an old implant and just touch up the lift first and then come back later, or just change out the implant. Those are people also to really think about your blood supply. Sure, random pattern usually does okay, but in an augmentation mastopexy that can be fraught with hazards right and left, I think those are really patients you need to think about.
I mean, I would just say from my end, I tend to be maybe a little bit on the more aggressive side, like what Brad was saying. I've done, so many thousands of these surgeries. And so I tend to do almost all one stage, even if it's sometimes 10 or 11 centimeters of vertical movement of the nipple-areolar complex. But I think the key is really to minimize your undermining. So I always leave like a dermal pedicle, almost always a superior dermal pedicle to the nipple. I do the minimal amount of undermining around the areola to get it to move. And sometimes it's surprising how little undermining you really need to do to shift that nipple into place. So if you're maintaining good blood supply, and these are on primaries, obviously, but even on a lot of my revision cases where the tissues were thinned out, I haven't had any real trouble with nipple-areolar loss. But again, I have a very specific way of de-epithelializing, minimal undermining, leaving that superior pedicle. I think if you do that, you can protect yourself, and then you can maybe get more, do more cases where you're doing a primary, because obviously patients don't want to do 2 stages in general. So if you feel comfortable, you can get an equivalent result. That's usually going to be the patient preference as well.
And the real challenge in that is that you, Rob, are very aggressive at your debulking, and you feel very comfortable that the lower pole does not provide any circulation to your nipple-areolar complex. So I think you're even comfortable going under the nipple-areolar complex in the deep parenchyma and resetting some of that retroareolar tissue to debulk it. If you do that, because then that makes it fold better when you're putting that, you're not stuffing all of that 10, 12 centimeters into that areola with all of that tissue deep to it. That's what leads to problems, either over augmentation or over resecting skin or trying to stuff all that volume into it, because then long term, you're going to have a waterfall deformity like you described. Short term, you are going to have circulation problems. That's not because you cut too much of the dermis around it. It's because you packed all the volume in there and you get a constricted
venous congestion.
Yeah,
you get venous congestion and you get into big trouble that way.
Yeah.
Agree.
Yeah. That's one of the things that with my practice anyway changed quite a bit from when I started till now, is that I almost always will do some lower pole debulking, because you just find that tissue just rolls off the implant. It's just kind of almost a guaranteed waterfall, especially in those bigger patients.
Mm-hmm.
And not to take anything away from, I know this is a talk about implants, but if I have a patient who's fairly large breast to begin with, these days I'm usually doing a mastopexy with upper pole fat grafting as opposed to putting an implant in a lot of cases. But I think there's obviously a very strong role for implants in many patients, but you have to have all those different options available depending on the patient anatomy.
Absolutely.
My mastopexy, my breast reduction, and my mastopexy are the exact same operation. And I take out full thickness down to pec fascia, the entire lower pole. On every case, I don't undermine it all laterally, but I will undermine superiorly as much as I need to. And I have a hard cutoff of about 10 centimeters, 30 nipple to notches, the furthest I'll go in a single stage.
So I hope the listeners of this are paying attention to the fact what we have in common is the success of an augmentation mastopexy in any body other than that very thin-skinned augmentation I described with a little bit of skin tightening. For the people that are breast ptosis and heavy-breasted, you have to debulk the lower pole for long-term success. And if I told you the number of surgeons who actually just deepithelialize that lower pole or just take the skin off, they don't undermine the flaps at all, and they pack all the volume into the lower pole, and the implant sits high, of course, and you have all this breast tissue at the bottom for it as their augmentation mastopexy, and then they wonder why their scars widen and the mastopexy fails long term, and they always get that sort of waterfall deformity. It is because of lack of debulking that lower pole and controlling the shape of the lower pole. And sometimes it's not just even debulking, but it's actually when you're closing that fascia, that deep fascia over the implant, that you're shaping that and you're closing it and tightening that posterior lamella or that posterior breast capsule around to sort of reshape and tighten your lower pole to support it, almost like using a mesh in a way to support it, debulk the lower pole, will lead to, in my experience, a better long-term result and not those catastrophic problems with circulation problems, because like Mindy had mentioned, it's venous congestion from trying to pack all that volume into the breast.
One other point I want to make is that with a lot of these surgeries, there's a strong role for using some kind of resorbable mesh or a material to help support the lower pole, because you're debulking all this tissue, you're adding this implant. Especially if you're debulking in the retroareolar area over the muscle, but you've done a dual plane procedure, if you don't restabilize that muscle somehow, it's going to window shade on you. And I think, you can certainly suture it back up to the parenchyma, but I usually like to add in a resorbable mesh as sort of a pec extension to add that sort of pectoralis mesh internal bra stabilizing the implant. So now you have your internal framework, and now you're just basically wrapping your envelope around that framework. But if the envelope is too thick, that's going to rotate off. So you have to thin that out and then do the mastopexy on top of that. So I do conceptualize it as sort of the implant framework with the muscle and the mesh to hold it in place, and then the skin envelope with debulked breast tissue, particularly in the lower pole, to give you the longevity. Because obviously you can make something look good on the table, but that doesn't mean it's going to look good after 6 months or a year or 5 years. So obviously, even with all these maneuvers, you can still have problems, but if you take care of that debulking, add reinforcement, do everything properly, you're giving the patient the best chance at having a good long-term result.
Great. These are all great points. And actually, from the only layman in the room right now, it just makes sense that if you're just deepithelializing, pulling all that tissue, like you said, in the center without reinforcing, where is that tissue going to go, but over time have laxity, just like the tissue you had before, which is why they're getting a mastopexy aug. So thank you for those points. And then I love actually you're talking about the soft tissue reinforcement. It sounds a lot like doing an underlay technique for ventral hernia repair, that you have to have that basis of structural support underneath, and then over the top you can bring all those layers together and hopefully avoid some of the tissue healing problems that center portion as well that people are afraid of. So let's go into the different levels of ptosis and how you correlate it to different surgical techniques. So of course, grade 1 ptosis, or most doing, or do you even offer a crescent or a circumareolar mastopexy at all?
I find crescent lifts are pretty much a virtually useless technique, except for minor adjustments. Because if you try to do anything more than maybe a centimeter adjustment, you're going to distort the areola.
Right.
On the flip side, I think the circumareolar mastopexy technique, which actually, thanks to Brad, I wrote that chapter in his upcoming textbook. But I think it's a very, very versatile and useful technique. It has a bad reputation because it's misused by a lot of surgeons in the past, where they should have done a vertical mastopexy or an anchor scar, and they're trying to overuse this technique. So when you think about a circumareolar mastopexy, it's going to have a compressive effect, so it's good for pointy breasts, not good for flat breasts. So you wouldn't want to use it for patients with like a lot of glandulotosis, but it's great if you just cinch things up. It'll pull that skin up onto the breast better. You can reduce areola size. You can shift the areola into different positions on the breast. So I think it's a very useful technique for like those, mild grade 2, the mild glandulars, just patients who it's not too severe, where you just need a little extra tightening.
Great. And anyone else want to comment on the use of circumareolar when they do it? And also suture technique, is it a wagon wheel, or are you just going around? Let's start with you, Dr. Altman.
So I very rarely use that operation, except for what Dr. Cohen just mentioned. I've rarely seen a patient where they look better with a circumareolar than they would have looked with nothing or with a vertical. I think most patients you can get a good result with a circumareolar didn't need anything other than maybe some areolar reduction. But if they are triangular, or if there's large areola that the patient wants reduced and there's less than about a centimeter of movement, I will use it. Whether I do just a circumferential purse string versus a wagon wheel technique is more based on what my intent of the procedure is. So I would say 90% of my circumareolas are unilateral, right? They're done just to achieve symmetry of nipple position when there's a small difference between them. With the exception being that triangular breast that you spoke about. I think it worked really well. And if I'm just trying to reduce an areola and maintain size, I will wagon wheel it. But if my goal is to raise that nipple, I feel that the wagon wheel puts equal superior and inferior force on that. And so it's counteracting my goal in the surgery. So in that case, I'll almost free it up so it's on a vertical pedicle, and then I'll tack it up to the superior portion and then do a purse string.
Is that still the case if you're doing more of an elliptical shape of the circumareolar, so that it's more resection at the top versus the bottom, or just universally across the board you find?
I try to keep my resection almost always as close to a pure circle as possible. Okay. Not necessarily with the nipple in the center of that circle. That circle can shift superiorly, but I tend to keep it fairly circular just because I feel it reduces the irregularity of the wrinkling when you cinch it down.
And I tend to do mine much more as a vertical ellipse for that, because when you tighten it, you get the elevation. It turns into a circle when you do that. Versus when I do a circle based on the tensions, it can become an oval. So it's just a technical part about that. I tend to do more of a wagon wheel, but definitely, and Rob can talk about his technique to do it, and Lou Bucky. Others have found ways to imbricate the dermis and use other ways to control it. The idea, though, is that something more than a circumferential stitch is kind of useful in a way. And then and maybe Rob talk about dermal shrinkage using cautery. The one thing I would say, though, is as we think about levels of ptosis and what you do, I don't think we should think about circumareolar mastopexy in that way, because it means it's a way of us dealing with ptosis, and it doesn't really deal with breast ptosis. The only thing that deals with breast ptosis is the implant you place. So, but if you need to reposition, reshape, reduce the size of an areola, and definitely in a tuberous breast deformity where you want to widen the breast, it has great utility. And I think we all use it in that place. As a way of treating breast ptosis as a term, I would say I use my implant for that. And as Jason had mentioned, often you get the same result kind of with a breast augmentation or a periareolar augmentation, because all you're really changing is the areola position or shape with that particular procedure. Otherwise, the breast itself looks the same with either one. Rob?
Well, I think to that point, I think it really varies on the patient's skin. So if you have somebody with sort of a thicker, tighter, more elastic skin, then if you try to do much, like in terms of significant skin excision with the circumarea mastopexy, it's just going to stretch out again, so it doesn't work very well. But if you get those patients with the very thin, crepey skin where you cauterize the dermis and you see the whole thing just shrinking down, you can do a very aggressive circumarea mastopexy pattern and have it look great with no pleats because the skin will shrink into itself. So I think the easiest way to tell for that is just physically pinch the skin together with your hands once you've made your pattern and see is that skin coming together easily, or you have to putting a lot of tension on it. One thing I do feel like there's more horizontal forces and vertical forces on the closure. So I always make my vertical length about a centimeter, half centimeter at least to a centimeter longer than it is wide. Otherwise, I found that I was getting horizontal ovals when I had two circumferential circles. So that's one thing I just wanted to point out from my personal experience anyway. As far as the suturing, I think a multi-layer approach is really important. So I start with, like you were sort of alluding to before, I deepithelialize first. I don't even cut the dermis. I just do pure deepithelialization. Then I cauterize. And when you're taking tension off the dermis and cauterizing, it'll shrink the dermis down. So it's already doing a fair amount of the work for you before you even put a suture in. Then I usually use like a 3-0 PDS, bury the knot at the 6 o'clock position, and almost do an imbricating stitch all the way around. So you're taking almost all the tension off the skin before you even get started with your next suture. Then I tend to do sort of more of a wagon wheel style with a proline, but I don't do the like a few, I kind of do quite a few. It's almost like a deep subcuticular suture, locking the areolar diameter down. But if you put too much strain on that suture, it's going to cheese wire through. That's why that deeper PDS is taking the pressure off. And then after that proline is in with the knot buried deeply, then I can do just a monocrystal subcuticular closure. And that really holds up well over time. I haven't had a lot of issues with scar spread or stretching or that kind of thing. But again, it's a judgment issue. For people who are not doing it a lot, I would start more conservatively, figure out, how it's working for you, and then get more aggressive from there. Because if you do an extremely aggressive circumarea mastopexy when you shouldn't, you can create an almost unfixable problem for the patient. So I've seen patients with these massive stretched out areolas with thick scars where somebody tried to do a circumareolar when they really needed a vertical, and that's a disaster.
And Dr. Haws, I saw you nodding along the whole time. So anything you want to add there? And then if you could kick us off on kind of the next stage, where you're doing a vertical mastopexy. We discussed a lot of the deepithelialization only versus debulking, and kick us off with your opinions there. So back to wagon wheel or not, or what do you do for circumareolar?
I agree with Brad and Rob and really with Jason, that the circumareolar is really not for a lift. It's more for maybe areolar repositioning, definitely for tuberous breast, and for controlling the size of the areola. And the more tension you put on it, the worse it's going to look and the more it's going to spread. I've been astounded over all my years in practice how much an areola can spread if it's not done right. That being said, and I like the wagon wheel. I think it's really helped with not getting so much herniation of the nipple, which is what you're trying to fix with the tuberous breast. When I go to a vertical, and again, I think now most residents are used to using verticals. People coming out into practice, that was certainly not Brad and I's experience. We probably were more self-taught with vertical mastopexy. But it's for those people that you want some lift of the lower pole, that you don't have a tremendous amount of excess in the lower pole, that you really want it's taking a dart out, and you are making the breast more conical. And that's why it works so well with the circumareolar, because you are affecting the height of the areola, the size of the areola, but that vertical extension is what creates the conical nature of the breast. And I agree, the more bulk you have of breast tissue down there, the more tension is on your scar, and you have skin that wants to stretch to start with. That's why you're doing a mastopexy. You're already dealing with skin that is not high quality skin for the most part. So I think debulking is important so you can put things back together in one piece. And just deepithelializing, there are some places for that for just a mastopexy, but there's not very many, and it's certainly not with a mastopexy augmentation.
Okay. So for that, the deepithelialization only is more for a little lateral and medial, just skin tightening versus an actual lift. Yeah.
A little weight loss. You're not increasing volume. This is not somebody who's, it's someone who's just deflated, who's lost tremendous weight, who just wants to look okay in her bathing suit. But just deepithelializing is not going to give you any strength. It's going to stretch out again. And it's more for probably like a B cup, small C cup breast. It's not for bigger than that.
So really somebody that has a constricted lower pole or an inferior, maybe a tuberous breast, but maybe a constricted lower pole, often you're going to be expanding that lower pole with your approach. And once you've expanded that lower pole, you may have a little horizontal laxity that you want to bring in, but you've just thinned them out because you're trying to stretch that lower pole. That would be the case where I would not really want to do much more than just tighten the skin, because there's not much
there.
My implant in that skin, and so I would deepithelialize and reshape it because I don't have anything to debulk in the lower pole in the first place, and I've just thinned it out.
Well, I think with the opening discussion, most of you, or really all of you, said for most of the case you do some level of debulking. So let's dive into that. Dr. Altman, what kind of pedicle are you choosing, if you are, and if that's necessary, and what is the kind of the main tenets of your debulking in someone who gets that initial need for a true mastopexy aug?
Sure. So I would say the vast majority of the mastopexy augs, I'm going to use a superior pedicle. I'm of the mindset that if I need to go to that medial pedicle, this probably is not a patient for a combined procedure. Most of the time, they're going to be longer than that 6 centimeter distance. I will. There's a separate set of circumstances where I'll use a supromedial pedicle, and I'll get into that in a second. But other than that, they're almost all going to be vertical pedicles. I do my mastopexy is exactly the opposite of the way everyone was taught. I make all my incisions and do my debulking immediately at the beginning of the surgery. Take out the tissue. I know what implant I'm putting in before I start. So my whole surgery is based off my marks. I cut all the way down to pec fascia, medial and vertical, leaving it on a superior pedicle. Most of my lifts are going to be wise patterns. I love a vertical lift, but I look at it kind of like a short scar facelift, that I'm not going to eliminate a hidden portion of the scar at the sacrifice of a result. So it has a great utility in that patient that has that shorter lower pole, but I don't hesitate for a second to take out a horizontal portion at the bottom as well. The patients I use I go to a supromedial pedicle on are patients that have significant amounts of asymmetry. I find that there's a lot of asymmetry, especially in the nipple position. The length of the pedicle is going to be so different from one side to the other that you're going to be stacking more bulk on top of your implant on that longer side. And it's going to be almost impossible to compensate for that with implant volume on the other side, the way it kind of sits like a snow cap on top. So in those patients, I'll go to a supromedial pedicle where less of the pedicle is sort of imbricating on top of the central mound of the breast, and it allows me to create more symmetry. My goal in those cases is to use my lift to get equal tissue volume. I want my implants to be as close to the same as possible because you get such discrepancies in the upper pole when they start to get different. So I'll try to equilibrate the tissue volume with the reduction or lift portion, and then go on and place my single size implants.
Yeah, so I do it a little bit differently. I mean, I totally agree with the concept of trying to make the breast as even as possible, as opposed to trying to use a very significant implant difference when that's an option for you. Same concept I use for fat grafting. I try to equalize the breast before I fat graft, so you're not doing more on one side or the other, because otherwise I think you are setting yourself up for a higher risk of post-operative asymmetry down the road. I personally like to do the implants first, and I'll do the dual plane, do the reinforcement if I'm going to, and then try to close a little bit of the soft tissue to cover and seal off that space, because I want that to be the most sterile part of the procedure. So that's before there's nipple shields on, before the nipple's exposed, before the really getting into the parenchyma. I like to have the implant in place and covered up. After that point, nipple shields come off. Then I'll do my, usually I'll pre-mark the mastopexy pattern based on my experience, but I'm always kind of prepared. And in some of the chapters I've written, I've shown sort of a marking system where you can make adjustments on table very easily. So I think it's really important to have, potentially to have some marks going down the chest with sort of plumb lines going down the breast, so that if you need to make an adjustment during surgery, and let's say the patient shifted a little bit or whatever, you're going to make sure that you're not setting the nipples off by accident. Because sometimes you kind of think what pattern looks right for you, then you put your implant in, start making adjustment, I always staple patients, sit them up, make sure I'm happy with how things look before I make any final decisions, because there's a lot of variables going on as far as the tissue laxity, how much volume you're going to add. And I tend to be more flexible. I have my own operating room, so it allows me a lot more flexibility in terms of implants. So I will use sizers when I'm setting things up, and then I put my final implants in after I have everything looking the way I want it to look, as opposed to pre-selecting implants. But obviously there's a lot of excellent surgeons who do it the other way. So it's just, I think it's more of a personal preference thing and how you're used to doing it.
That's a great point. And I was on the ISAPS masterclass a couple weeks ago with Jim Grotting going through this too. And he was talking about doing the superior or supermedial pedicle first and then placing the implant after. So let's just go around the horn, which you typically for most patients do first, the tissue-based resection or place the implant. So just go around. Calobrace.
Yeah, I totally believe in tailor tacking. And so, and I believe that if I'm going to get an exact skin envelope around the implant I'm choosing, I do know what implant I'm going to use. It doesn't change it, but I like to fine tune my final skin excision. So I put the implants in, create my pocket, control the pocket. Then I plan my soft tissue redistribution, my mastopexy, set the patient up, confirm complete symmetries, both the top down and bottom up, to make sure everything's exactly how I want it to be. I make adjustments because I'm not that good at drawing to know exactly what it's supposed to be with that implant in place, how the soft tissue is going to function as it's maybe submuscular implants, and you got all that volume that may come down differently on one side versus the other. And then once I have a tailor tagging that I think is perfect, then I just do my soft tissue debulking and develop my pedicle and do the rest of it.
Okay, Dr. Haws. Implant or tissue first?
Implant first, then I tailor tack. I believe in tailor tacking, and I think, remember, this is a varsity class, everybody who's watching this. So Don't jump right. Dr. Altman can do this. He's got the skill set. Brad and I are going to be tailor tacking back here in the back.
Tailor
I put in the implant. I'm like Brad, 90% of the time, unless there's significant asymmetry or something else going on that I'm not sure about size, I know the size going in. I make my pocket, I put the implant in, like Rob, I try and close up some soft tissue over it so I'm not epithelializing, contaminate the implant that way. And I've already tailor tacked to kind of guide where I'm going in to put the implant, but then I tailor tack again, sit the patient up, look where more needs to come off, look where the nipple needs to go, and go from there.
So I love that you guys are talking about choosing your implant ahead of time, but obviously in the OR, you're dealing with a lot. How much debulking, how much tissue is actually there, and when you're pulling it together, you can customize that, as you've all said. From my time in ICG imaging, I think really knowing where that main perfusion is coming to the nipple as well as to all the breasts you're resecting. Do any of you use a technology for the assessment, or are you just tapping the skin and doing clinical assessment? Does anyone use ICG, or would it be warranted if it was more cost effective?
I don't think it's too necessary. I think if you do, if all the principles we're discussing, superior pedicle, you can be a little bit more conservative in what length you're willing to adjust in one stage. Like I said, I tend to be a little bit more aggressive on that. Don't do a lot of undermining. It's really very hard to damage the blood supply as long as you're not being aggressive in terms of cutting off the subdermal plexus or adding so much volume that the like we were talking about earlier, where you start getting that venous congestion of the nipple areolar complex because there's just too much stuff inside the skin. That's where the tailor tacking can be helpful too, because if you can get it together before the debulking, then after debulking it's going to be even a little bit lower tension. So
and I think the point is, for the surgeons, you have to understand the blood supply you're working with. And if I ask in the ORs, and I do lots of preceptorships, often surgeons know techniques, but when I ask them what is the blood vessel supplying that, they don't really for sure know, right? And that's in a primary case. The number of surgeons who actually do an inferior pedicle-based augmentation mastopexy is surprising. And it was just presented at Atlanta breast meeting by a surgeon who I then stood up and said, you have to know that that's a random blood supply if you're doing that. Because remember, the blood supply to the central or the inferior pedicle comes through the fourth deep branch of the IMA, which is sacrificed in placing the implant. So the moment you place the implant, the main blood supply to the central or inferior pedicle is gone, right? That's why you hear us all using a superior pedicle, because it's the second superficial branch coming across the top of the breast, which means you can do a lot to the lower breast and do it. if you get by with a augmentation mastopexy with an inferior pedicle, it's because you're undermining less. You're keeping more of the random blood supply to that central breast tissue intact, but that can lead to all the problems we've talked about before. So I think just starting with knowing why you do it. If it's important in primary cases, it's quadruple important in secondary cases, because now you're going back and doing mastopexy on people who already have implants, and maybe they've had an inferior pedicle reduction. So their superior and medial pedicles were probably sacrificed during that initial breast reduction, and now you have to go back and do an augmentation mastopexy. Now what pedicle are you using? Well, we tend to design that as a superior pedicle, but we know at the end of the day that that's not really pedicle blood supply, because that was probably sacrificed in the first case. So once again, you have random blood supply you're depending upon. So in those cases, we would tend to undermine less often, just because we're a little more worried about blood supply. So just recognizing where's your blood supply. Pat Maxwell taught me a long time ago, you can design anything you want, then stop and say, okay, but where's my blood supply? And then you alter your design to make sure you secured that and thought about that, especially in secondary cases.
I would say, like, any surgeons doing inferior pedicles on a regular basis should really kind of reassess why they're doing that, because whether you're talking about breast reduction or a mastopexy or an augmastopexy, that's a tissue you don't really want, is the heavy tissue at the bottom of the breast. And it tends to be some of the weakest blood supply. So I really don't see a reason in almost any case why, unless there's prior surgery that prohibits it for some reason, why a superior or superior medial pedicle, it shouldn't be the preferred choice in almost any single case. They're just, the inferior pedicle, in my opinion, should kind of go the way of the dinosaurs. It's just sort of an outdated pedicle that keeps the tissue, not only is the tissue not where you want it, but you're working against gravity, pushing the inferior pedicle up. Whereas with a superior medial pedicle, the fullness is where you want it, which is in the superior pole and the cleavage area, and it's hanging naturally with gravity. It just makes so much more sense to me. So
I would say one of the most common causes I see for secondary cases, I do a lot of secondary mastopexy augs, and I'm curious as everyone's opinion there, but one of the most common reasons people will come in, or that I'll find when they come in for a secondary mastopexy augmentation, is that an inferior pedicle was used the first time, and that there was inadequate debulking of that lower pole, where there was loss of blood supply because of that random element once they put the implant in. But it's a very common theme in the secondary cases I see. And the question I had for everyone else on the panel is, how do you guys approach your secondaries in terms of an unknown previous pedicle?
I always supply mine, almost always by a superior blood supply. There's not a lot written about that. Frank Lista and Jamil Ahmad wrote a paper where they were just basically, it wasn't about augmentation mastopexies, but if you're going back on a secondary breast lift, even in an inferior pedicle-based initial operation, they felt the safest way to do the follow-up surgery was basing it superiorly as a blood supply, that, and going ahead and resecting, because you always want to resect some of that bottom tissue, so you disregard that initial pedicle as the safest way. You add an implant to it, and it complicates the story, right? Because you've taken out even more blood supply. I always base mine superiorly with the knowledge that potentially I have a random blood supply, even with an augmentation. Because remember, in a breast augmentation, in making that pedicle, when you're making that pocket, if you go too medially and you're really trying to be aggressive at getting cleavage, you can injure the second or third branch of the IMA at the level of the chest wall before it comes up. So you're never really quite sure that their pedicle blood supply, even with the breast augmentation, is intact. So you just go into it with the knowledge that this could be a random blood supply, and supply it in that way, and don't be overly aggressive, like Rob has mentioned, in that dissection around that areola, because you just feel like all the tissue coming into that is precious because you're not fully 100% confident in the pedicle. It will keep you safe almost always.
Subdermal plexus, you got to preserve that subdermal plexus, as Rob said. That's where you just deepithelialize around the areola and preserve as much as you can. I know it's not coming from below. Where it's coming from, it's not coming from below.
a lot of these revision surgeries, I mean, sometimes you're dealing with basically skin on capsule, with a touch of fat in between.
Right.
Clearly, it's not really a real pedicle, and yet still, I'm able to like completely tighten and revise these breasts. So it's the minimal undermining the subdermal plexus, and in a way, it's kind of like a delayed flap. It's already been stressed out to the max, so now this nipple is surviving on just this thin layer of skin. So as long as you preserve that subdermal plexus, that's probably what it's been living off of anyway, and it seems to do fine in most cases. But also, as you're doing your dissection, keep an eye on the nipple, and if you start tailor tacking the nipples, turning purple or blanching a lot, you need to release it or kind of figure out what you've done to alter the blood supply, although thankfully that's very rarely an issue.
Just to reaffirm what you guys are saying, because I think seeing is believing, especially for, as you said, younger surgeons who you ask them, they don't really know where that blood supply is coming. When we did, hundreds of reconstructions and spied it afterwards, you removed the entire central blood supply, obviously, and we saw almost always the main one to the nipple was coming superior and somewhat medial across the nipple. Sometimes there'd be a little bit random lateral. Very rarely did you see much coming up through the IMF, even when we did the mastopexy was through a radial incision. So just to reaffirm what you guys are saying, north is safe, even for either. So sorry, Dr. Altman, you were going to add something there.
No, I was curious everyone's input, but I do the same as Brad. I keep them almost all on a superior pedicle. The main difference between it and a primary for me is I don't undermine superiorly as far. So I'm really just taking that. Essentially, I'm removing whatever the lower pole is left. Luckily, on a secondary case, the distance you need to move that nipple is typically less. The main reason I see these secondaries is that it's either bottomed out or they haven't debulked. So the nipple position is often pretty good. In the secondary, maybe you need 1, 2, 3 centimeters. So it's very easy to do that on a superior pedicle. Even when I know the previous pedicle was inferior, I don't hesitate to go to a superior and see if you have minimal issues.
And I think that's an important point too, that a lot of times in a secondary case, especially if an implant's involved in the primary, the lower pole is stretched out a lot, right? And sometimes the nipple-areolar complex is in actually adequate position. And if you don't need to move it, don't move it. Do some sort of a sailboat or some other mastopexy in the lower pole. Don't move your areola, and then you don't have to worry about the circulation as it relates to that. It's also important if somebody's had an augmentation before and you're going back to do a mastopexy to remember it probably matters what pocket it was in before, because if they're submuscular, I feel a little more confident because I have the thoracochromial vessels and everything coming in the perforators supplying it. So I have a little bit of a comfort level with the fact of that. And also whether or not I leave the capsule or not, right? Because the capsule can be a great source of circulation and stability to, especially as Rob mentioned, those very thin skin envelopes. So having to get rid of the capsule and or knowing I'm subglandular with very thin tissue, then my sphincter tone goes up and I'm actually more concerned. So there's many aspects as you're assessing that case where you can go, okay, well, they're under the muscle now, I'm going to leave the capsule. I feel much more confident now in my approach versus the exact opposite. And especially today with the number of total capsulectomies that we're all doing for various reasons of texture and or BII, et cetera, that we're dealing a lot more with threatened envelopes that need some sort of
tissue.
Feeling confident doing that.
Sure. Well, and you touched on submuscular versus subglandular. Any other reason to avoid submuscular other than, a really thick pectoralis muscle that's gonna show or window shade, or is anyone doing mostly subfascial or subglandular when they're doing these? Let's just go around the horn.
Well, I know that I'm not going to talk about me, but I know that Dr. Sigalov, who's a partner with Dr. Cohen, has been doing a lot more of subfascial augmentexies and
with mesh reinforcement
of mesh or scaffolding with it as a nice approach. Let's admit it, an implant was meant to be behind breast tissue and not behind muscle. Muscle does get in our way. It tends to create a place between the implant and the overlying breast tissue. So when you're under the muscle, and that's why we dual plane it, you're higher risk over time of getting a waterfall deformity where your implant is more stable long-term than the overlying breast tissue. So if it was right behind the breast, that would be better long-term for that. So I do believe that a very natural result can be had. But like everybody else, sometimes when you go subglandular into a breast of these patients with bad soft tissue, it's hard for them not to just become a stretched out mess after that, because you lose the support of the muscle for that. So I think what Dr. Sigalov is trying to do is say, okay, that is a problem. How can I stabilize that? We were using textured implants to do that for a long time, but now the concept of maybe a smooth implant plus a scaffolding of some form would help you to do that and get more correction. Because when you put an implant behind the breast itself, it does half of the work of rejuvenating that breast compared to doing a submuscular implant. I still put most of mine under the muscle currently.
Yeah, I guess I can go next since you were talking about my practice a little bit. So I personally do almost all dual plane. I do find that, if patients are very, very muscular and like a weightlifter or something like that, that can be certainly problematic. For most, even I've operated on plenty of very athletic patients. They still do fine with dual plane, but I usually let them know not to do pec building exercises after surgery as much as they can help it. So not a lot of bench press push-ups, or I do think you start to get inferior lateralization of the implants over time. I think there's a role for subfascial for sure. Dr. Sigalov gets beautiful results, but a lot of it's about patient selection. You need to make sure they have at least 2 to 3 centimeters of soft tissue pinch, or else you're going to see the implant. They have to have pretty decent quality tissues, or else have some of the problems that Brad was just alluding to a couple minutes ago. He always, whenever he does a subfascial, he's going to combine it with a resorbable mesh to stabilize the pocket, so the weight of the implant is being offloaded on the material and not onto the skin. And so that's I think a really important concept as far as, if you're going to plan these surgeries and you're going to be over the muscle, you need to take extra steps to protect that patient from some of these problems. And it's not like the muscle itself is going to support the implant, because obviously the muscle is on the top half of the implant, but just having that extra, I don't know what it is about the muscle, it gives it a little bit better compression where there's not quite as much, I think, projection forces on the skin. So it seems to sort of stabilize that result a little bit better, and you have to be a little bit more cautious. But certain patients is a very good option, I think.
Okay, Dr. Altman?
I'm putting all my implants in a dual plane submuscular.
Okay.
Yeah. I do get nervous on secondary cases when I know they're over the muscle.
Sure.
I'm going to be an outlier here, but I'm in Nashville, and there's probably higher BMIs than there is in Florida or
Plenty of tissue coverage.
Beverly Hills. I got good tissue coverage.
Yeah.
If they have good tissue coverage, and I still have a few women who want saline implants, believe it or not. But as long as they're doing silicone, the silicone more cohesive gels are such minimal rippling now. If they have good coverage, I give them subglandular as an option for both my AUGs and my Mastopexys. I'm probably 50-50 or maybe 60-40 more subglandular than submuscular, simply because of, my patient population. But again, it depends. And if they're a CrossFitter who's not going to stop flipping tires, then I discuss when their implant's going to end up underneath their arm at some point, or they've got to stop doing that particular exercise, like Rob said, at least for 3 or 4 months. But so I give them the option.
I've also worried about, capsular contracture rates in the subglandular pocket. That's always been a conversation. Speaking of Frank List and Jamil Ahmad, they had just published a paper that came out in ASJ, was coming out in ASJ, where they reviewed the first 3 years of texture versus smooth. And although to a certain degree, the texture does a little better than smooth subglandular, there's kind of showing there's an equivalence, but they have really low capsular contracture rates in the first 3 years, with even the smooth implant on top of the muscle at like 2%. So, but capsular contractures increase over time. And so I still have that sort of part of me that's concerned now that we're using so many smooth implants, we're, above the muscle, that I'm going to start dealing with long-term capsular contractures, because historically that's been the case. You do well for a while and then they start to increase. And at some point in time, by the time you realize you shouldn't have done that, it's too many.
You're years down the line.
Too many,
hundreds of patients.
So many.
We'll be following them now, though. I mean, we're all going into an age where we're going to be following these patients for long term to be able to look back, which is good news. And props to both societies for enabling that in the very near future. So thank you, Dr. Haws, for bringing up a little bit on technology. So as a gratuitous shout out to my employer, so that we don't end this discussion without talking about implants. Now, what's the interplay for you between having soft tissue support and then whether or not you choose a more cohesive gel, less cohesive gel? I'm assuming it matters less if you have more tissue coverage. But any thoughts there around cohesivity and
It's all about the upper pole. And for years, people would say, oh, I've got to have an implant with my breast lift so that I'll have fullness up top. Well, with the older gel implants that weren't as cohesive, that really wasn't necessarily the case, and certainly not with the saline implant. But now that we have cohesive gel implants, I can give people upper pole fullness, and I can do it, with a lower profile implant that's a wider base without having to go great big, which used to be what we had to do. So that has really changed and has been a great tool in my hands to be able to do that. And I think for people who don't want that, who really want a slope, who want more of an anatomic, softer upper pole, then we can use the less cohesive. But most women want upper pole fullness and want more cohesivity. I used to say if you could just dial in a grade 2 capsule, 90% of my patients would be happy. Well, now we can get that kind of look with a more cohesive implant.
Okay, so in the Sientra portfolio, at least HSE plus for you for those patients?
Yes, the 107s.
Yeah, thanks. And Dr. Altman, how about you?
So it goes back to what I said at the very beginning of this. When you think of the role of your implant in a mastopexy aug, it's really there for upper pole fullness. That's why I'm using it. If I didn't need upper pole fullness, I wouldn't need an implant. I can get a beautiful natural look without an implant. I can do fat. I can do an autologous inferior-based subdermal tissue advancement. So I 100% of the time put a 107 implant in on my mastopexy augmentations. I just don't see a point. And not only am I using exclusively high cohesive gel in my mastopexy augs, but my previous patients that I did before these were available, I've probably switched most of them over at this point, because they will come back, especially in Miami, they will come back if I put a softer implant in there that there's not enough fullness, that they don't look like their friend that had an augmentation. So I find the high cohesive gel, both for distribution of that volume and to allow me to use not necessarily as big or as high profile an implant on my mastopexy augs. I really like having that option available.
That's interesting. So the gel type does matter across and within manufacturing portfolios. So I appreciate that.
But I think that remembering that the 106 is still an optimally filled implant. So it maintains a lot of its upper pole compared to even the 107. And it just has a slightly increased cohesiveness to it. It's HSC plus versus the HSC. So, compared to our 4th generation gels from the other manufacturers, Sientra never had a 4th generation gel in their portfolio. So, they had the 105s, which were not optimally filled, but beyond that, they're textured and smooth, were optimally filled. So, the performance of an upper pole, of the implant in the upper pole, has a lot to do with the control of the lower pole, of course, but then it is the optimal fill of the implants, the gel-to-shell interaction, and the cohesiveness of the gel. But each and every one of those parts makes a difference in how it performs in that particular pocket. And there are times when I don't want as round of an upper pole as a 107 would deliver for me. I do think the profile matters, as Jason said. So it depends on what profile you're looking at with that. In a secondary case, I do find that there's times when if you put a higher profiled 107 or one of the more cohesive gel implants in a pocket that's less controlled, it becomes like a little round ball on that chest wall, and it starts to roll around, and it has a harder time holding onto the chest wall compared to a gel that's a little bit softer. And so I do find a place in secondaries where if I want to hold its position better, I sometimes find it easier to hold that position with a softer gel than with the 107. So I don't think I just use it as a panacea for everything. I'm really selecting it based on the overlying soft tissue and the level of the chest wall and the ability to control the pocket. And based on how much volume and roundness my patients want in the upper pole, I can then use those implants in varying amounts to be able to achieve that in a more fine-tuned way.
Great, thank you. And Dr. Cohen, if you want to wrap up the conversation on whether implants matter in these mastopexy augs.
Sure. I think they do to a certain degree. I'm very much sort of in alignment with what Brad just kind of talked about. I sort of feel the same way. I really think, like, for me anyway, for upper pole management, it's mostly about lower pole management. And that's why I use a lot of reinforcement materials, because if you control the lower pole, you're controlling the upper pole. With Sientra implants, if people haven't handled them before, I think they may have like a misconception that like the 107 is a very stiff firm gel, like an Allergan cohesive implant, which it's not. I find that very stiff implants, exactly what Brad was saying, it's kind of unforgiving, problematic sometimes. If you have a very firm implant, it kind of rattles around the pocket. You can see the edge of the implant too much. It's not forgiving enough. And you need a certain amount of forgiveness, especially in patients with thinner tissues, where the implant can kind of spread and move and kind of interact with the patient's tissues, not as a separate thing, but almost as a cohesive unit, so to speak. But with the Sientra implants, if you feel like an HSC and an HSC plus, you'll feel a difference, but it's not a dramatic difference.
Very little.
It's still, they both have a very soft feel. For people who are not used to using Sientra, but maybe have used Allergan in the past, it's kind of mostly equivalent to like maybe hovering around a soft touch in terms of its softness. But the cohesiveness is actually quite a bit stronger with the HSC plus than a cohesive implant with Allergan, and the HSC is still stronger than the soft touch. So you have a very strong implant that's still soft. So that's one of the reasons I think that a lot of surgeons who do a lot of these mastopexy gravitate towards Sientra implants, is because you have a strong implant, but it's also a very forgiving implant at the same time. And I think, as far as whether you use HSC or HSC plus, I think it's just case by case basis as far as, what your goals are and what you're trying to achieve. But I think with either implant, you're going to get still a more forgiving style with a really good strength. That's why I use those implants. I tend to use probably more 106s and more HSC than HSC plus, but they're both awesome implants. If I have somebody with rippling issue, usually it's traction rippling, you have to fix the pocket, but if it's a patient where you think having a little bit more cohesiveness is going to help, then HSC plus is a good way to go. So I can't lose with either of them, in my opinion.
All right, thank you guys so much. And actually, for anyone still watching this discussion, if you're interested in the implant technology, go back to our Sientra TECHnews Breast Augmentation 1, where Dr. Cohen does quite a thorough review of the differences in the implant testing. But just as to confirm what you're saying, the jump from the fourth generation of the other manufacturers to just our baseline HSC is much bigger in performance. It takes 40% more force, but is only about 10% more firm. So already you're talking about a much more cohesive, form stable device without being firm. The HSC Plus actually is only 9% more force. It's a lot more shape stability there, but still quite a bit softer than the cohesives of the other manufacturers. So I appreciate you guys making those points. I appreciate the discussion here. We'll definitely be back for more. But let's just go around the horn. Final thoughts on what your advice you would give for surgeons new and old in their practice to achieve great results in mastopexy. Dr. Altman, let's start with you.
I think it's been said many times. I think it's an operation you approach with caution and choose your patients wisely until you build a significant comfort level with your ability to elevate a pedicle and your ability to wrap that parenchyma around an implant. Start with grade 2 ptosis cases with less bulky patients in your exam room. Elevate that patient's nipple by imbricating to see how easy that superior pedicle is going to fold for you. And as you get more comfortable, you can push the limits to longer pedicle lengths and larger breast parenchymal volumes as you go, but start with those easier cases and build a comfort level for how these tissues shape and how that nipple moves.
Thanks. Dr. Haws.
Agree. Start slow. You can always go big later. Start with not the worst tuberous breast or the worst asymmetry. Start with the grade 2 ptosis, put the implant in first, tailor tack, measure twice, cut once.
Great. Dr. Calobrace.
I would say don't confuse pedicle design with skin excision design. And
Right.
So we all approach these as a vertical approach, superiorly based blood supply. We control the parenchyma, we put the implant in, and then take your skin out where you need to, which is going to mostly involve an incision around the areola vertically and some level of skin in the fold. Take your vertical excess out at the fold and forget about trying to keep these as vertical incisions with vertical scars. Never let your areola to fold distance go greater than 6 to 8 centimeters at maximum. Anytime it exceeds that, take the extra skin out, because this is no mastopexy. This is an augmentation mastopexy. You can leave vertical length excesses with a mastopexy and they'll fall under the fold and hide away. with that implant there, they're going to stretch out. So when in doubt, just take more skin out and take it out along the fold.
Probably just a few points that we've already discussed. I know Jason brought some of these points up as well. So patient selection, do a really thorough evaluation of your patients, the tissue layers, not just the soft tissue, but the rib cage and the bony tissues and the muscle. It's all going to add up to asymmetry you have to be aware of. Managing patient expectations is probably one of the most important things. You don't want to compromise the shape, as Jason said earlier. You don't want to compromise the shape to avoid scars. If you need the scars to get the best shape, that's what you should be doing. And if patients ask you not to do the appropriate scars, they're still going to have the expectations of the result they want, and you're going to set yourself up for failure. So you either just don't do the surgery if you don't think the patient understands what's involved. And then the last thing, which is a point that I made earlier, is just leave yourself a little bit of flexibility in the operating room. So to that point, make sure that you have the whole array of mastopexy patterns that you think you might have to get into. You don't want to paint yourself in a corner where suddenly you need a inverted T scar, but the patient's only agreed to a lollipop scar, and now you're kind of stuck. That's a bad situation to be in. So always over predict what you might need. And then I think tailor tacking is really important. If you just grab a stapler and put things together, you can see what it's going to actually look like. Sit the patient up. You should not be doing these surgeries unless you're sitting the patient up and seeing what they look like during the surgery, because anything can look good to the patient lying down. And once you sit it up, sit the patient up, that's when you really see what things look like. So make those adjustments, and before you commit to necessarily making incisions you can't take back, if you haven't had the experience that some of the surgeons on the panel have had, to just go ahead and do it as right up front.
All right. Well, thank you guys all for your time and sharing your experience with surgeons across the country. I think this has been very useful discussion, and appreciate, again, you joining us on Sientra Tech News. Bye, guys.